Hey, you beautiful people! Today I'm starting with a new subject and a smart topic acute liver failure. Please pardon me with my image of a glass of wine, and I would like to remind you that not all liver failure are due to alcohol, and also let's discuss some other reasons for failure. Starting with the liver failure, it is an acute onset liver injury which will include coagulopathy as well and hepatic encephalopathy. There is no evidence of pre-existing liver disease. So if only and only jaundice is there with elevated liver enzymes, this is called as acute hepatitis. But when it is associated, the jaundice is associated with coagulopathy, it is said there is an injury. The mortality in acute liver failure is almost 40 to 95%. So let's just make us very clear that when there is this elevated liver enzymes with the jaundice, it is said it is an acute hepatitis, and when there is a jaundice as well as a coagulopathy, that means the INR is say more than 1.5, then it is the acute liver injury. But when there is an acute liver injury with a coagulopathy with hepatic encephalopathy, it is said as acute liver failure. It does not include ascites, remember. So we cannot say a patient with ascites, it is he or she he is suffering with acute liver failure. So now there are clinical features that there are prodromal symptoms. There is a icteric phase and there is a hepatic encephalopathy phase. So to prodromal phase, that means the patient will be having malaise, weakness, fatigue, okay, all such features. And then icteric phase, that means patient will be having elevated bilirubin, and that will tell us there will be a yellow discoloration of eyes, sclera, and skin. Then there is hepatic encephalopathy. So duration wise, we are dividing it into hyperacute, acute, and subacute. Hyperacute says that it is less than 7 days. If it is 7 to 28 days, then it is said to be acute. That means it is 1 month. And 1 month to 3 months, it is said as subacute. But when I'm saying it is a patient is a chronic liver disease, I mean to say that it is more than 6 months of the disease course. So in case of a hyperacute, it is like a fast bullet train. So there will be drastically rising bilirubin, and there will be more and more encephalopathy, and cerebral edema is much more in these patients. But there is a spontaneous recovery. So we expect this to be in a paracetamol poisoning in case of hepatitis A and in case of hepatitis E virus. When I'm saying it is an acute one, so there will be bilirubin which will be raised, but the encephalopathy is much more in case of acute, and the recovery chances are less as compared to that of hyperacute one. And this is the seen in hepatitis B virus. When I'm talking about the subacute, there will be more bilirubin raised as compared to that of hyperacute and acute, and there is encephalopathy which will be less. As we see the CLD patients, they have something which is called as myoinositol, and that is making them resistant to that of cerebral edema and encephalopathy. In a hyperacute and acute, there is no such thing like myoinositol, so the patients are suffering from cerebral edema, and they are more prone for hepatic encephalopathy. So there is a non-paracetamol drug induced cases. We shall see what are the other drugs that can cause this liver failure. So they can cause this subacute to chronic one. Okay, so there is no ascites, remember, and there is no varices in the acute liver failure. No varices, portal hypertension is not there. There is just a jaundice, there is just a coagulopathy, and there is just a hepatic encephalopathy. So what are the etiologies of liver failure now? So in a developing country, we can see hepatitis B virus, and in case of a developed country, we have seeing more of a paracetamol as a cause. There could be other causes like that of viral, and we shall see other causes like mushroom poisoning, or because of certain drugs that can cause, or hyperthermia, even that can cause the acute liver failure. And pregnancies and the other factors which are associated with the pregnancies can also cause that of liver failure. So coming to the hepatitis A virus, this is something which has a hyperacute onset and it has a spontaneous recovery. No need to worry, it will subside on its own. And the other factors that make it a more risk disease, that is because of a drug abuse if the patient is abusing, and his age, that is an older individual, pregnancy, and alcohol, bnc associated viruses, so that can cause certain problem for us. Other thing is, when the patient is posted for the liver transplantation, we need to give him immunoglobulins. This is important because he has a risk of developing hepatitis A virus. Coming to the hepatitis B virus, as we all know that this is something which is through that of the um, bloodborne, and that is the needle stick injury or any blood transfusions, right? And the factors that are the important as the age and the gender. And there is a co-infection like hepatitis D virus. This is also we are something which are aware of. Okay. And the diagnosis is done on the basis of the IgM, HBC antigen. They remember that in these patients, HBsAg and HBV DNA viral load is negative. Okay, so this is important because it is an acute event. Coming to that of hepatitis E virus, which is more dangerous in case of a pregnant woman because it comes with a fulminant course. Um, so the mortality is almost by 20%. The other viruses that could be involved are the herpes simplex virus, and there is also herpes zoster virus can be associated. It can be HHV6 virus associated, or there could be Ebola or cytomegalovirus, or dengue could be one of the cause. So that the patient, whenever we see certain mucocutaneous lesions, we need to address them, and we need to treat them with acyclovir. This is the norm, and this has to be done. And in such patients, the AST/ALT levels is almost like 10,000 or so. So that can give us a clue. And whenever I'm expecting any MODS, like that is a multi-organ dysfunction syndrome, in case of dengue, in case of rat kill compound consumption, rat kill compound consumption can also produce liver failure. So in such situation where there is MODS, so I cannot expect any transplant in these patients. So the other organs are affected in these patients, so I cannot transplant. That is the deadliest thing. Then coming to the drug induced liver injury, so we said that there is a dose dependent and dose independent. Dose dependent most of is the paracetamol, most common cause for the drug induced in a world. And when it comes to dose independent, there is two things: there is an idiosyncratic reaction and there is an hypersensitivity reaction. When I'm saying there is an idiosyncratic reaction, I talk about rifampicin more, and when I think there is an hypersensitivity reaction, I am talking about halothane, and also remember phenytoin. The most common cause of drug-induced liver injury in India is the ATT, that is the anti-tubercular treatment, and mostly it is the rifampicin that is associated, as well as there is isoniazid, right? So on the biopsy, what will I see? I will see necrosis, I will see steatosis, I will see endothelial damage, I will see look for sinusoidal obstruction. Okay, so where else can I see steatosis? So there is valproate toxicity or tetracycline, L-asparginase, bleomycin, azacitidine cytotoxicity. Endothelial damage is seen in, remember, TH azathioprine. So in case of pregnancy, where we see these changes, that is preeclampsia causing acute fatty liver, preeclampsia and HELLP syndrome, they can cause acute liver failure. And other thing is the acute fatty liver of pregnancy. So to differentiate these things, I will make another topic uh, uh, discussing the liver diseases in pregnancy, so that we can differentiate on a routine basis, on a daily basis, because the acute fatty liver of pregnancy will have bilirubin much more raised, that is up to 30 or say 35 bilirubin. But when I'm saying that it is an HELLP syndrome, the bilirubin has to be like 5, 6, not more than that. Coming to the vascular causes, there is a Budd-Chiari syndrome, portal vein thrombosis, and autoimmune causes like that of autoimmune hepatitis. Okay, um, so there is a mushroom poisoning, that is the Amanita phalloides. That is, whenever I have an ingestion of 2 to 3 mushroom caps, I can expect there is a poisoning occurring, because these are something which are water insoluble and these are heat stable, so they can cause hyperacute liver injury. So one of the thing is the paracetamol, other thing is the viruses, and this is the manita or the mushroom poisoning. So this is having separate core phases, that is the acute gastroenteritis phase, then there would be a certain recovery phase, which is that is for 1 to 2 days, and a patient will feel better, and after that there will be acute liver failure that is occurring up to that of 4 to 5 days. So the toxin is that of alpha amanitin. So antidote that can be given is the penicillin, that can be readily available in our setup, and there is a silibinin according to textbooks. I have not seen any case as such of mushroom poisoning. Another MCQ that could be a potent question, that is the diagnosis of mushroom poisoning is based on the SQD criteria. This could be asked anytime. The other cause is hyperthermia, as I said, and other lymphoproliferative malignancies like HLH, hemolymphocytic histiocytosis, that could be there. Remember those causes also. Coming to the diagnosis, so I will be doing CBC of the patient. I will look for the LFT KFT levels. Then I will go with the serum amylase to find out any pancreatitis also, because the patient can come with them ODS picture, so I am not aware. Then I'll think of coagulation test also, electrolytes. Hypoglycemia can occur in these patients because there are decrease in the glycogen storage. Again, there can be hyperglycemia because of insulin resistance. So this is important. BSL monitoring in this patient, blood sugar level is considered. Then arterial pH and serum lactate levels. So it is said that more than 1.2 would be the arterial pH, or lactate would be more than 3.5. Okay. Then on the UHG, I can see shrunken liver or hepatomegaly. Now, this hepatomegaly is seen in case of acute liver disease, ALD patients, okay, alcoholic liver disease. But in case of Pachyeri also, or in case of hemochromatosis, or in case of metastasis also, these patients can see hepatomegaly. So on the biopsy, we have already seen what else we can say. And as a toxic screening, I know it's not done in our centers, in our setups, but yes, we can also screen the patient for any alcohol, and of course the viral antibodies have to be done. Detailed history has to be taken from the patient, outside consumption, blood transfusion, and so on. Any past history of any jaundice, this will enable us to locate where could be, what could be the cause, and etiology. So we see that ammonia levels is raised because there is hepatic encephalopathy, but remember that it is only of prognostic value, it has no diagnostic value as such. So more than that of 200, there would be raised intracranial hypertension. So only on the basis of the ammonia also we can start the patient on dialysis, remember this. So what are the complications of acute liver failure? So there is encephalopathy, we have already seen that. Then the next thing is intracranial hypertension and cerebral edema, and that is causing the encephalopathy. Hemodynamic changes and circulatory failure. Patient can anytime go into septic shock. There could be other secondary infections. There could be acute kidney injury, and there are hematological abnormalities, including that of DIC. And the patient do not need any prophylactic FFP or cryoprecipitate. Remember that. Some centers do follow this, but it's not written in the protocols. So coming to the hepatic encephalopathy, we are aware that ammonia is a factor, but other things are also important. Octopin is one of the thing. Then mercaptans, there is also the amino acid derivatives that are important. GABA receptor agonist. Then there is decrease in the glutamate levels. That is one thing to be kept in mind. Then activation of the GABA receptor complexes. So these patients are already drowsy, so whenever they become whenever there is a requirement for any sedative, the ideal sedatives are the propofol or fentanyl. That is important because they can sometimes become erratics and we need to sedate them. I know we most of the times we use midazolam, but that is not the choice. The propofol and fentanyl is the choice. So yes, we can perform NCCT brain in such patients with that of grade 2 grade 3, grade 4 hepatic encephalopathy, and consider patient to be shifted in ICU whenever you think it is a grade 2 hepatic encephalopathy, right? And on the CT, what will you see? There should be a loss of gray and white differentiation. So now we have this intracranial pressure monitoring that could be done in case of young patients who need monitoring, who are in hepatic encephalopathy in case of acute kidney injury or renal failure, ammonia when it is more than 200, then there could be done. And then when there is a shock, that is the vasopressor needs is there. So other things that could be tried is the upcoming treatment modalities have changed. There could be, one thing is the mannitol or hypertonic saline that could be used. Other thing is hyperventilation, that is they believe that the PCO2 to be maintained between 35 to 40 mmHg, and hypothermia can be induced. The other things are the hypernatremia, hepatectomy, endomysitis. How to diagnose intracranial pressure? This is all theoretical. I have never seen, I have never done. So this is the optic nerve sheath diameter that can be used to measure the intracranial pressure, and the other thing is the MCA, that is the middle cerebral artery Doppler. So what could be the treatment for the cerebral edema? This plays a main role because this is the one which is responsible for the hepatic encephalopathy. One thing is the mannitol, but carefully have to be given mannitol because these patients tend to be having a MODS picture, they can have renal failure. So when the ammonia gets uh, it reacts with the glutamate to form the glutamin, and this glutamin is responsible for all the cerebral edema as it is osmotically active. So remember, this is the glutamate which is getting converted to glutamin. But in CNT patients, I have discussed that it secrete the neuron secrete the myoinositol that balance the osmotic pressure. So hepatic encephalopathy is not very much seen because this is a chronic liver disease. So we have seen that there should be in hyperventilation. What does an hyperventilation do? So there is the CO2 that would be stimulating, and whenever there is decrease in the CO2, there is decrease in the intracranial pressure. So now other features or other things that can be done for these patients is elevation of the bed edge by 20 to 30 degree, mean arterial pressure to be maintained between 50 to 60 mmHg, hyperventilate the patient between the 35 to 40, correct the volume overload, okay. Reversible causes like that of hypoglycemia, seizures, these have to be controlled. Then we need to minimize the head turning, then avoid internal jugular vein cannulation, optimize the PEEP, treat hypotension in seizures and hypoxemia reversible causes, intratracheal ecnocan for the respiratory suctioning, correct hypoosmolarity, mannitol has to be administered, hypernatremia between 150 to 155, and liver transplant can be considered if the patient satisfies the King's College criteria. So N-acetylcysteine that can be given to the patient if in case of early liver failure. Then factors for the liver transplant. So King's College is the most important one. In case of the paracetamol acetaminophen cases, this should be satisfied, that is the pH is less than 7.5 for more than 24 hours and the lactate is that of more than 3 after the fluid resuscitation. Now, all the following has to be considered, that is PT is more than 100 second, INR is more than that of 6.5, serum creat more than 3.4 milligram per deciliter, or there is an anuria, grade 3-4 encephalopathy. So this is very important. Then next coming to the non-acetaminophen cases. Now, in this the PT is more than 100, INR is more than that of 6.7, or any three of the following. That means the age, if the patient's age is less than 10 or more than 40 years, there is an acute or subacute onset of illness. Then if there is an unfavorable etiology, serum bilirubin is say more than 17.5 and PT is more than 50 seconds, or INR is more than 3.5, just a half of these. Okay, so on the liver biopsy, other criteria that could be asked as an MCQ is that hepatocyte necrosis more than 70%. So remember this value. As I've already discussed, the arterial phosphate more than 1.2, lactate more than 3.5, Apache 2 score says more than 15, MELD score more than 22. SQT criteria is used for mushroom poisoning, and Swansea criteria that is seen for acute fatty liver of pregnancy. So what will you do for the nutrition of the patient? It is just like a normal individual, that is 35 to 40 kilocalorie per kg per day, protein to be 40 gram per day. Now paracetamol toxin, very important. How much is the dose? It is less than 4 gram that is can be given to any patient, but in case of CLD it is half a dose, that is less than 2 gram per day. So it causes hyperacute injury. We all are aware of this. Now, there could be a therapeutic misintervention. That means the patient can have paracetamol with alcohol, or maybe other drugs, or any of the viruses could be positive. So this is one thing. Then the peak bilirubin is by day 3. 1, 2, there is no features as such, but day 3, the elevation of bilirubin starts. So on the biopsy, there is a central lobar zone 3 necrosis. Just like autoimmune hepatitis, this is also having a zone 3 necrosis. And when the patient consumes 7 to 8 gram of, of paracetamol, there could be a necrosis seen. 15 gram, there could be an hepatotoxicity, and 20 gram, there would be acute liver failure. So now, how does a paracetamol is excreted? How does it goes away, and how does its sization takes place? It is by the glucuronidation and sulfation pathway that is excreted. Now, if this is saturated because of increase in the paracetamol levels, we say it will be metabolized by that of CYP450. Now, even if this is saturated, then it could be a NAPQ, that is the N-acetyl p-benzoquinone, and if it is also saturated, they form an adduct, and this is causing oxidation and then hence causing liver injury. So for the NAPQ, we give NAC, that is an N-acetylcysteine, and that is converted into glutathione. Okay, and that is the non-toxic mercapturic acid, and it will get converted non-toxic mercapturic acid, and then it gets excreted. So that's when NAC is important in case of rat kill poisoning. Also, in case of early paracetamol poisoning, early patients who arrive within their 4 hours, or say like that, then we can initiate the patient on NAC. So if the patient arrives within 3 to 4 hours, we give a gastric lavage to the patients with paracetamol poisoning and activated charcoal. There is a normogram. This is very important. Rumac Matthew normogram, which says more than 2 standard deviation. Then we start the NAC within that of 15 to 16 hours. So if the patient has more than that of 20 gram of paracetamol, straight away start the patient with the N-acetylcysteine without normogram, because this is a very, very high dose, and this is a lethal condition then. Okay, so the loading dose of NAC is saying 140 milligram per kg of the body weight, and the maintenance is 70 milligram per kg body weight. Thank you so much. I hope this is helpful for you all, and start treating the patient and start detecting the etiology of acute liver failure other than out of the alcohol. Thank you.